Hello, guys. A great day to everyone. So, today we are going to talk about the infectious diseases of the heart. So, we'll talk about microorganisms that are invading our heart. So, we start out with the first topic, which is rheumatic heart disease. It is also called as the rheumatic endocarditis or myocarditis, depending on which layer of the heart is the one that is infected. So this is usually a complication of rheumatic fever. We are avoiding complications to occur once rheumatic fever has been diagnosed because this can later complicate to this one, which is rheumatic heart disease. And it may occur within days or weeks after untreated group A beta hemolytic streptococcal infection. So you always remember this. The group A beta hemolytic streptococcal infection. This is the bacteria that is responsible for infecting the heart of the patient. So usually there's an infection of the upper respiratory tract if the child or a patient has rheumatic fever. But if it's not treated, this will lead to rheumatic heart disease or RHD. Risk factors of having streptococcal infection are the following. It may be this one, before we go to the risk factors, it may be transmitted via oral or respiratory secretions. One of the risk factors is malnutrition. So if a patient is malnourished, they won't have enough proteins in their body to create antibodies, which will help ward off infection. Or overcrowding. So you're exposed to a lot of people. You live, let's say, for example, in Metro Manila, where the population is too dense. Imagine living in a metropolitan area of 12 million people. So there's overcrowding there. And there's low socioeconomic status as well. We can relate malnutrition to this because in patients or in clients who have low socioeconomic status, they usually have not enough food to eat. That's why most people from the low socioeconomic status, some of them can be malnourished. And for a family history of having a rheumatic fever, since this is a communicable disease, they may transfer the infection from one family member to another. Pathophysiology. Once the infection from Streptococcus is acquired, there will be the development of rheumatic fever. And the inflammatory and immunologic processes will be activated once we are exposed to the Streptococcus. And once the immune response has been activated, there will be autoimmune response. But where will it go? These immune complex deposits will go into the endocardium. So that's the inner layer of the heart. So this is the immune system. Once these antibodies are activated, they will accumulate later on or make deposits later on to the endocardium of our heart. So the classic signs and symptoms of rheumatic fever is pericarditis during the acute phase. So the pericardium is inflamed. And myocarditis, the inflammation of the muscles of the heart. Lesions called Ascoff's bodies in the interstitial tissue, as well as swelling and fragmentation, leads to the formation of fibrotic nodules and scars. So this can cause scarring in the area where there is inflammation. Endocarditis, once this happens, it will cause valve leaflet swelling. So the valves are going to swell and later on can cause erosion along the lines of the valve. Blood platelet and fibrin deposits can also occur. And lastly, carditis. The whole heart is inflamed. So this is a severe heart inflammation. So once that happens, there will be decreased contractility, decreased cardiac output, embolic events. This is critical since embolic events can lead later on to myocardial infarction and chronic valvular disease. That was the previous topic that we've talked about. So these are the cardiac tissues or cardiac muscle that is involved. And as you can see here, this is the normal one, but this one has created scarring of the myocardium. So if the myocardium is scarred, it will have a hard time pumping out blood out of the heart. So signs and symptoms, the classic signs of rheumatic fever major criteria would be carditis, erythema marginatum, Sydenham's chorea, migratory polyarthritis, so they can also experience pain in their joints, and subcutaneous nodules. Minor criteria, there's fever, there's arthralgia. Arthralgia is pain in the joints. Leukocytosis occurs, so there is an increase in the WBCs. And there's an increase in the erythrocyte sedimentation rate. The normal value is at 0 to 22 millimeters per hour in males and 0 to 29 millimeters per hour in females. Also, there will be an increase in C-reactive protein. And the normal value should be below 10 milligrams per liter. And if you are going to observe the PR interval, it is somehow prolonged for patients who have rheumatic heart disease. The, what they call this? The relevance of the erythrocyte sedimentation rate and the C-reactive protein, once these are increased, it means that the patient is suffering from an inflammation. ESR and C-reactive protein are indicators, or if it is increased, or they are increased, they are indicators of inflammation. Okay, so here, this is an example of the one that I've mentioned, one of the major criteria, erythema marginatum. So it's usually seen in the thorax of the patient. This one is Sydenham's chorea. So this is involuntary movement of the patient. I'm going to play here a video for you to check. So this is an example of a patient suffering from Sydenham's chorea. It's a pediatric client who is suffering from rheumatic heart disease. So here, these are involuntary movements that are done by the patient brought about by this disease. And this is the subcutaneous nodules rather, that are seen in the patients. And arthritis can occur in the joints of the patients as well. There are also small translucent vegetations or growths in the valve flaps. That occurs, this can lead to valvular regurgitation or stenosis. It can complicate to this. And later on, if the muscles of the heart are not effectively pumping out blood anymore due to scarring brought about by this disease, signs and symptoms of heart failure will be evident, either it be left-sided or right-sided heart failure. So here, you can see some nodules growing on the flaps of the tissue of the valves of the heart. Just this one. They are obviously inflamed. So how do we diagnose this? Throat culture is done. So they are going to take a swab of the secretions from the throat. in order to determine the bacteria that is responsible for the disease. Increased WBCs and ESR levels will also indicate that an infection is occurring. And an increased cardiac enzyme level will also be seen in the patient. But the one that will really confirm that the patient has rheumatic heart disease would be for the positive anti-streptolysin titer, or the ASO titer. This would confirm the presence of group A beta hemolytic streptococcus in the patient. So treatment goals is to stop or to prevent the infection, of course, the streptococcal infection. So we need to control it. We need to prevent the patient from developing an autoimmune response that can lead later on to cardiac damage, like what I've explained earlier in our pathophysiology. So the treatment, once the patient is already diagnosed with rheumatic fever, they are going to be given antibiotics. The drug of choice for it would be penicillin, and it's parenterally given either through IM or IV. If patients are allergic to penicillin, the doctor is going to prescribe erythromycin instead. It's part of long-term therapy. So as nurses, our responsibility prior to the administration of antibiotics is to check or assess for allergies. But if the heart failure is already evident in the patient who has rheumatic heart disease, then the heart failure is going to be treated. Or if the valves have complicated, valvuloplasty and valve replacement is going to be done on the patient. But to prevent number 2 and 3 from happening, early treatment of the disease should be done through antibiotics. We will not allow the patient to complicate into these types of heart disease. Next, we have infective endocarditis, or also known as bacterial endocarditis. This is the infection of the valves and the endothelial surface of the heart. Risk factors for this disease include those who have cardiac structural defects. So those who have congenital heart diseases, for example, older people are also at risk for this, or those who are injecting IV. So drug users who are injecting drugs via IV, they are at risk to develop this, especially if they are, most usually they're not using the aseptic technique when injecting themselves with illegal drugs. Patients who undergo invasive procedures are also at risk, or those who have implants or invasive equipment. Patients who are also receiving immunosuppressive drugs or corticosteroids, since these drugs will suppress the immune system of the body, they are also at risk of developing this disease. So pathophysiology, once the bacteria is in the bloodstream, this can travel through the heart. Let's say, for example, you're a drug addict and you did not practice aseptic technique when injecting yourself with an illegal drug. So you unscrupulously injected yourself with an unsterile syringe. So once that happens, invasion of the endocardium by a microbe, either it be a streptococci, enterococci, staphylococci, fungi, or rickettsiae, will invade our endocardium. And the inflammatory process, infection will occur along the endocardium. Remember, anything or any site where a battle has happened between the WBCs and the invading microorganisms, scarring can result afterwards. So if that can happen, scarring will result from inflammation of a tissue If that happens, there will be deformity of the valves. The chordae tendineae is going to rupture, or blood flow obstruction because the valves have narrowed it. It's stenotic, and heart failure can result later on. Signs and symptoms of infection is evident for any patient who has had those microorganisms in their body, like malaise, anorexia, or loss of appetite, weight loss, cough, back and joint pain. There are influenza-like signs and symptoms, so there may be cough, there may be stuffy nose or runny nose, and so on. Intermittent fever is evident in a patient who has bacterial endocarditis. Splinter hemorrhages. These are blood clots that run vertically under the nails. They can be present as well. Osler's nodes can be present, which are painful red raised lesions found on the hands and feet. And Roth spots or retinal hemorrhages can occur in the eyes of the patient. You can also hear heart murmurs from the patient. And if an embolus has been formed, signs and symptoms of embolism can be present, such as difficulty of breathing, shortness of breath, chest pain, and so on. Janeway's lesions can also be present. So before we discuss the other signs and symptoms, this is an example of the Roth spots on the eyes of the patient. So even the eyes are damaged because of this infection. So here, the one that you can see here on the nails of the patient are splinter hemorrhages. And these are the Janeway lesions. As not like that of the Osler nodes. Osler nodes are raised lesions on the patient's hands and feet. They are painful. Janeway lesions, they are similar, but they are not painful. So that's the difference between the two signs of bacterial endocarditis. So I'll repeat. The difference, Osler's nodes are painful red raised lesions on the hands and feet. While Janeway lesions, they are non-painful, and they are maculopapular red lesions found also on the hands and feet of the patient. So diagnostics, they are going to obtain a blood culture to determine the bacteria or the microorganism that has infected the heart, or an echocardiogram is going to be done in order to detect the heart structures. If a heart failure is already occurring, if the valves are functioning well, so management to prevent infection from occurring. So again, antibiotics are going to be used on the patient. They are administered parenterally. Take note, this is done for 4 to 6 weeks. 4 to 6 weeks. So if prevention fails, again, antibiotics will be done. So to eradicate the invading microorganism. But if the patient is infected with any of those microorganisms that I've mentioned earlier, to prevent the occurrence of bacterial endocarditis, antibiotic therapy is still going to be done. But if it complicates, if causes scarring of the valves, deformities of the valves, valvular surgeries, which I've mentioned from my previous lecture, is going to be done. So nursing management, we are going to assess and monitor for signs and symptoms of murmurs, embolism, infection, and heart failure. For the drugs, of course, it's our responsibility to check for any allergies before the administration of any form of antibiotic, and ensure appropriate infusion site and tolerance to the antibiotic therapy. Monitor for signs and symptoms of any adverse effects of those as well. Now we go to the myocarditis. This is an inflammatory process involving now the cardiac muscle, the myocardium. It may remain unrecognized throughout the course of the illness, or it's asymptomatic. Risk factors for myocarditis include the following: those who had infections or viral infections, bacterial, protozoal, or parasitic. Or again, those who have been receiving immunosuppressive drugs or corticosteroids. And those patients who may develop sensitivity reaction to long-term drug therapy. So they will be at risk for myocarditis. So this one may begin as an inflammatory or as an allergic reaction and may affect one part of the myocardium. So at first, one part of the myocardium is affected, and this may spread to the other parts of the myocardium as well. So once that happens, heart dilation will occur. Thrombi on the heart wall can develop. So a blood clot can develop. And later on, degeneration of muscle fibers will occur, leading now to heart failure. So there will be scarring, again, of the muscle tissue of the heart, the myocardium. That happens, scarring of the myocardium can result to heart failure. Instead of pumping effectively like this, it will now be weak and thready. So that is how heart failure is occurring. The heart doesn't pump effectively. Signs and symptoms, so like what I've mentioned, it may be asymptomatic. Fever may be present, fatigue, dyspnea, palpitations, chest or abdominal pain is also felt. Heart murmurs can be heard upon auscultation and irregular rhythms. But if this complicates, since it's asymptomatic, it will now lead to heart failure, depending on which side of the myocardium is affected, whether it would be the right or left side of the myocardium. And always take note the differences between the right and left heart failure. Right-sided heart failure, the signs and symptoms are always systemic. For left-sided heart failure, the signs and symptoms are always pulmonary. We will discuss more of those on our next lesson, which would be heart failure. So, sudden cardiac death can also result from this disease. Diagnostics, again, blood cultures to determine the bacteria or microorganism that is causing the disease. Echocardiography will also be done to assess the myocardium of the heart, including cardiac MRI. So they are going to use MRI to visualize the cardiac structures. Take note, our responsibility for magnetic resonance imaging is to remove any metallic objects on the patient's body before undergoing MRI. We're also going to remove the wheelchair or the stretcher from the room where the MRI is going to be conducted, because these equipment can be magnetized by the MRI. Treatment, again, infection prevention, antibiotic therapy. So we are going to treat the causative factor. And if it fails, of course, heart failure can occur. Digitalis or digoxin is going to be given to increase cardiac contractility. And of course, bed rest will be given to reduce the heart's workload. So we are going to manage heart failure. That's a different discussion or lecture. And specific treatment for the underlying infection. So there are certain antibiotics that will be given depending on the type of microorganism that is causing the infection. And take note, never ever give NSAIDs to patients with heart failure, because NSAIDs can further cause myocardial damage. So do not give NSAIDs to patients with heart failure. What are NSAIDs? Examples of NSAIDs would be aspirin, ibuprofen, mefenamic acid, acetaminophen, paracetamol. So do not give any of those. And restriction of strenuous physical activities in order not to increase the cardiac workload. Avoid carrying heavy objects, for example, and avoid strenuous activities. Embolization precautions will be done. So elastic pressure stockings are going to be worn by the patient. ROM or range of motion exercises are also going to be done on the patient. And anticoagulant therapy is going to be given to the patient to prevent the formation of an embolus. Always monitor the patient's or any bleeding signs and symptoms from the patient when the patient is going to take any anticoagulants. And cardiac monitoring is also done. Now we go to the next topic, which is pericarditis. This is the inflammation of the pericardium. It may be acute or chronic and may be classified to what accumulates on the pericardium. There are two types, the acute dry pericarditis or acute pericarditis with effusion. So what happens here? So once the bacteria reaches the pericardium, which is the outer wall of the heart, it will be inflamed. And this is the effusion, the acute pericarditis with effusion. There will be accumulation of fluid in the pericardial sac. And once that happens, there will be rise in the intrapericardial pressure. So inside that sac that is enveloping the heart, which now will lead to cardiac tamponade. That pressure will cause the heart to pump ineffectively because the fluid that is inside that sac will put pressure on the heart muscle, causing the heart not to pump effectively. That is cardiac tamponade. So once cardiac tamponade occurs, the ventricles are not going to expand that much because of the pressure in the pericardium brought about by the fluid that has accumulated there. So once that happens, it may become thickened and fibrotic. There will be decreased elasticity and a formation of a scar. So once that happens, decreased contractility will occur. There will be increased diastolic filling pressure and decreased cardiac output. Again, this will lead to heart failure. Anything that decreases the cardiac contractility of our heart will eventually lead to the formation of heart failure. Signs and symptoms, there's pleuritic chest pain and a pericardial friction rub will occur. So here, once you auscultate the heart of the patient with a pericardial friction rub, you are going to auscultate an extra heart sound of to and fro character. So it's like dub 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 dub. And mild fever is also present. Once it complicates to heart failure, again, the signs and symptoms of heart failure are going to be present. There will be an increase in respiratory rate and heart rate as well. Pulsus paradoxus will also be present in this patient. I will send you another video regarding pulsus paradoxus later after this lecture in order for you to fully understand about this. And back triad, there's hypotension, elevated jugular pressure, and muffled heart sounds. These are the back triad of acute pericarditis. Hypotension, elevated jugular pressure, and muffled heart sound. So remember HEM, H-E-M. These are the back triad. So this is the sound of a heart that has a friction rub, pericardial friction rub. So here, you can see the pericardial sac is somehow swollen and there's water or fluid inside it. If that water or that fluid causes pressure on the heart will not pump effectively. So this is the video that I'm going to send to you later on.
Welcome to the Stanford 25 video on pulsus paradoxus. Pulsus paradoxus is defined as a systolic pressure drop greater than 10 with inspiration. Normally, during inspiration, the decrease in intrathoracic pressure will cause an increase in blood flow to the right side of the heart, leading to an increase in pressure transmitted to the right ventricular walls. Since more blood remains in the lungs during inspiration, a small drop in systolic blood pressure is expected. However, in tamponade, the increase in blood flow and pressure on the right ventricle during inspiration cannot be transmitted to the right ventricular wall, and is in turn transmitted to the ventricular septum. This in turn leads to a decrease in left ventricular filling, which causes a decrease in stroke volume and a much lower systolic blood pressure. To measure pulsus paradoxus, all you need is a stethoscope and a blood pressure cuff. To test for pulsus paradoxus, slowly look for the first corticoff sound that will appear, then disappear during inspiration. Next, slowly listen for when the first corticoff sound no longer disappears with inspiration. This clip was recorded from a patient at Stanford University with a pericardial effusion. Pulsus paradoxus can be a valuable clinical tool and has been shown to have a sensitivity of 98% and a specificity of 83% in predicting cardiovascular compromise. Along with tamponade, pulsus paradoxus can be seen in some patients with constrictive pericarditis, during asthma or COPD exacerbations, and less commonly in other clinical scenarios. Importantly, pulsus paradoxus may not be present despite a patient being in cardiac tamponade in certain situations such as aortic regurgitation and atrial septal defect. In addition to other findings such as an elevated jugular venous pressure, tachycardia, and shortness of breath, pulsus paradoxus can serve to be a valuable tool in the evaluation of a patient with suspected cardiac tamponade. This has been the Stanford 25 video on pulsus paradoxus. Thanks for watching.
Okay, that's it for pulsus paradoxus. Now for the diagnostics, CBC, there you can see that there's an infection due to increased WBCs and increased erythrocyte sedimentation rate. So inflammation is also present. Blood and pericardial fluid culture is going to be done to check the culprit, which microorganism is infecting it, and cardiac enzymes also will be checked to check for the efficiency of the myocardium if it's pumping effectively. Imaging studies, so chest x-ray, CT scan, or MRI is going to be done on the patient, echocardiography as well, and the ECG. For chest x-ray, there's not much to instruct to the patient before a chest x-ray, but for CT scan, sometimes they are going to inject a dye into the patient. So again, assess for any allergies from the radiopaque dye before the patient will undergo a CT scan. Treatment. Goals is to relieve symptoms and prevent or treat the pericardial effusion or cardiac tamponade. So this is the compression of the heart from excessive fluid in the pericardial space. So again, activity restriction is going to be done so that the patient will not, or the patient's heart is not going to put that much work on the body. Drug therapy. We are going to give analgesics and NSAIDs for the chest pain that the patient is feeling. Corticosteroids to reduce inflammation. Colchicines also are given to the patient. And of course, antibiotics, the appropriate antibiotic that is going to be done. For surgeries, pericardiocentesis can be done in order to remove that the fluid that has accumulated in the pericardium, or a pericardial window or partial pericardiectomy is going to be done, or a pericardiectomy will be done. These types of surgeries are just going to relieve the pressure from that fluid that is accumulating inside the pericardia. Our nursing management, it's the prevention or management of the infection. Again, we need to check for allergies from the antibiotics. And we need to know if the patient is also allergic to any analgesics, because there are also analgesics that can cause allergies. If we are going to give cardiac glycosides, we need to monitor for cardiac glycoside toxicity. If they have any visual disturbances, we need to report that immediately. Visual disturbances associated to cardiac glycosides. Restrict the activity of the patient. They should be in bed rest at all times. Monitor for the signs and symptoms of heart failure. Also monitor for signs and symptoms of reoccurring infection. We are going to instruct the patient about the surgeries that will be done and drug therapy as well, that they need to finish the antibiotic according to the number of days that the doctor has told the patient to take, and to assess any signs and symptoms of complications. We need to teach that to the patient as well once they go home. And avoidance of complications. Okay, so we'll continue with this. So avoidance of complications. The doctors, they are going to give antibiotics and relieve the, what do you call this, the pressure from the pericardium brought about by that pericardial effusion. And once these things are happened, the complication that will eventually lead to heart failure will not occur. So that's the goal of this treatment. And general nursing diagnoses for patients with infectious disease of the heart, activity intolerance. This is related to compromised oxygen transport, secondary to heart muscle dysfunction. So this is one of the things that you can use for nursing diagnosis. Risk for ineffective breathing pattern related to decreased respiratory depth, secondary to pain. So, agonizing for them to effectively, or lastly, last one. Although this is not an infectious disease of the heart, we are also going to discuss this because the heart is also what is this? This is an acute febrile illness. The cause of this is unknown. It's unknown. So once they ask you what is the cause of health, it is principally involving the cardiovascular system, vasculitis of the arterioles, venous capillaries, including the coronary arteries. So there is inflammation of these blood vessels. Panvasculitis of the main coronary arteries may cause stenosis or obstruction with aneurysm formation. Pericarditis, interstitial myocarditis, and endocarditis, phlebitis of the larger veins. So panvasculitis, pan meaning all of the blood vessels here are inflamed in Kawasaki disease. Usually, this one has geographic and season outbreaks. Geographic usually in the northern hemisphere, such as US, Russia, China, Japan, Europe, the northern Europe. This is where it is occurring. But this usually is occurring commonly in the Pacific area. So the name itself, Kawasaki, this is derived from Japan. So seasonal outbreaks, it usually is occurring during the winter season. Winter season. And I have a personal um, struggle with this before because my eldest son was diagnosed to have this. That was around 2017. And it's not winter here, but it was during the cold season here in the Philippines. And we are also in the Pacific region. That's why he is a patient that fits this description because Kawasaki disease is common in the Pacific region and it happened during the cold season, which is the winter season in the northern hemisphere. Because he was diagnosed with this in January of 2017. Fever for 5 days, and there's bilateral congestion of the tongue without exudation. Eyes are also changes of the mucous membranes of the oral cavity, such as erythema, dryness, and fissuring of the lips. This was what was seen on my tonsils. Doctors they thought at first it was measles. When they saw that his lips were healing, it was fissuring. They referred him to a cardiologist. There's also oropharyngeal ridging or strawberry tongue. Strawberry tongue is present in patients with changes in the extremities such as peripheral edema, peripheral erythema, and dislocation of the palms and soles, particularly healing. So the hands and the feet being healed, and this can be seen on the trunk of the patient. That is the polymorphous rash and cervical lymphedema can also treatment. The treatment, this is primarily supportive because it has no known cause. How are we going to treat it? Just to supportive treatment to reduce the signs and symptoms. So it's directed towards controlling fever, preventing dehydration, and minimizing possible cardiac complications. So intravenous gamma globulins will be given. It also depends on the weight of the patient on how much gamma globulins are going to be given, and this is very expensive. The treatment of my son's Kawasaki disease alone was very costly. He was given 24 vials of gamma globulin, and each vial costs 10,000 pesos. So just imagine how costly this disease is. Large doses of aspirin will be given as well to prevent thrombus formation since the coronary arteries are involved, because this can later on complicate to myocardial infarction once a thrombus has formed. So long-term treatment of aspirin is going to be given until the patient's coronary arteries are no longer dilated. And always monitor the patient's cardiac status through echocardiography, most especially the size of the coronary arteries of the patient. So that's how Kawasaki disease is treated. And it is usually supportive. We really don't know the cause. It is thought to be autoimmune, also thought to be caused by a previous viral infection, such as infection of the respiratory tract, brought about by a virus, but again, the cause is unknown. So again, thank you very much for attending today's lecture on infectious disease or infectious diseases of the heart. Please be ready for our term 1 exam, and this topic will also be included there. Again, thank you very much and have a great day, guys. Bye.